Welcome to NCLEX RN Review, produced by Nursing Tutorial and Consulting Services. This segment is Female Reproductive Part 2. I'm Judith Miller, and I'll be your guide as we continue discussing female reproductive. Our next topic for discussion is labor and delivery. So we went through pregnancy and talked about those complications, and now we're going to get this baby born. And I want us to start by talking about contractions. Sometimes we talk about these as being the powers of labor and delivery, or contractions. And you need to be concerned about three terminologies: frequency, intensity, and duration of contractions. If you look at the picture up here, you see that frequency is from the beginning of one contraction to the beginning of the next. It includes one full contraction. Now, duration is the length of one contraction. We usually measure frequency in minutes, duration in seconds. Now, intensity is the strength or intensity of the contractions. And remember, we need to when we assess intensity, the nurse assesses intensity, not the mother. Mothers don't, particularly primogravidas, just don't know what they don't know. In other words, they may say when their contractions are 15 seconds long, oh, they're terribly strong. Well, they don't know what's going to happen to them as labor progresses. So if you can feel the uterus and indent the uterus during a contraction, this is a very mild contraction. If you meet resistance, it's a moderate contraction, and if you are not able to indent the uterus, it's a strong contraction. You can also look at the fetal monitor, and that will show you the intensity of the contractions as well. Now, I want you to look at the slide here and note if the frequency here, so from here to here, is 3 minutes. And the duration of the contraction is 90 seconds. So tell me, what is the resting period? What is this length? Well, how much time is there between contractions? So frequency is 3 minutes. Duration is 90 seconds. The resting period is also 90 seconds. Remember that frequency is beginning of one to the beginning of the next. And if the contraction is 90 seconds long, there would be 90 seconds left, because there's 180 seconds in 3 minutes. There are some terms you need to be very familiar with. We're going to talk about presentation, and presentation means the part of the baby that is coming first. Now, this baby that I'm holding here, the presentation of this baby is vertex, so that the baby's head is coming first. What would this baby be called? This baby is a breech presentation. The baby is coming bottom first. Now, breeches are frequently delivered by cesarean section because they do present some problems being delivered. Sometimes we get the full bottom, sometimes you could get a footling or a single or a double footling where the feet actually come first. But presentation is the part of the baby that's coming first, either breech or vertex, head first. We hope vertex. About 90% of your babies come head first. Now, position refers to the part of the baby that's in the pelvis. Usually we're talking about the baby's head, and its relationship to the left or right side of the mother and to the front or back of the mother. So this baby is on mommy's left side with the baby's head. The occiput is the reference point when we have a vertex presentation. So the back of the baby's head is toward the front of mommy, or the anterior. So this baby is L-O-A. It's on mommy's left side with the occiput toward the front of mommy's pelvis. Now, this child is L-O-P. P. The occiput, the back part of the baby's head, is toward the back of mommy's pelvis. So this is an LOP. Now what would this baby be? So this baby is now on mommy's right side with the occiput toward mommy's back, the back of mommy's pelvis. So this is an ROP. And this child is ROA on mommy's right side with the occiput toward the front. Now LOA, which was this one, is indeed the most common presentation or position for the baby. We hope that babies are anterior. When we have a posterior position of the baby, that baby's, the hard part of the baby, the back of the baby's head, is actually going right down against mommy's coccyx and sacrum, and she gets a terrible backache with this. So not only does she have more back pain during labor, this baby has to make a bigger turn as it goes through the birth canal. So second stage is usually longer and more painful with a posterior presentation. It's important that you understand the terms station, effacement, and dilatation. Station refers to the location of the presenting part in the pelvis, and usually we're talking about the baby's head. And we're talking about where it is in relationship to the ischial spines, these little spiny things, pointy things here. So when the baby's head, and when we talk about the head, we're talking about the biparietal diameters. When this baby's head is at the level of the ischial spines, the baby's head is said to be engaged, or this is zero station or engagement. Prior to that, when the baby's head is up here, this is a floating head. And as the baby's head descends, it goes minus 4, 3, 2, 1, 0 at the level of the ischial spines. And now as it goes below the ischial spines, it becomes plus 1, 2, 3, 4, and then on the pelvic floor for 5. So station is the location of the presenting part, usually the biparietal diameters of the head, in relationship to the ischial spines. And station 0 is important because when the baby's head is snugly in the pelvis, engaged at station 0, it means that should the membranes rupture, the cord is very unlikely to prolapse. But if the membranes rupture when the baby's head is high, it would be easy for the cord to prolapse as the water goes gushing out. So station is important to note. Now, the next thing we want to talk about is effacement. And when we talk about effacement and dilatation, we're talking about the changes in the cervix that allow the delivery of the baby. Effacement refers to the thinning of the cervix or the loss of the cervical canal. So if we take a look at this, now we have a baby in the uterus, and here's your cervical canal right here. If we see this cervical canal, with the cervical canal, the baby can't come out as long as this cervical canal is present. It has to disappear. And this is effacement when it just pulls back like this. So now we have full effacement. We measure effacement in percentages. So this would be 0% effaced. When it's halfway down, it's 50% effaced. And when it's completely disappeared, there's no longer a canal there, that's 100% effaced. In primogravidas, we usually get most of the effacement before they start dilating very much. At multigravidas, they may they do more of it simultaneously. So now once we have effacement of the cervix, we then have dilatation of the cervix. And dilatation is an increase in the opening of the cervix so that it gets bigger and bigger, and we measure this in centimeters full dilatation is 10 centimeters dilated. Then this is big enough for the baby to come through. So effacement is loss of the cervical canal or thinning of the cervix. And then dilatation is opening of the increase in the opening of the cervix. 10 centimeters being full dilatation. Now let's take a look at a question that deals with this concept. A woman who is 40 weeks gestation is admitted in active labor. She is 2 centimeters dilated and 80% effaced. Which interpretation of these findings by the nurse is correct? The cervix is 2 centimeters short of full dilation and it is 80% thinner than it was before labor started. The cervix is still 2 centimeters long and 80% of the thinning of the cervix is completed. The walls of the cervix are 2 centimeters thick and 80% of the widening of the cervical opening has been achieved. Or the opening of the cervix is 2 centimeters wide and the cervical canal is 80% shorter than normal. Now, the correct answer is number 4. So it was 2 centimeters dilated. So the opening of the cervix is 2 centimeters wide and the cervical canal is 80% shorter than normal. It's 80% effaced. I also want us to talk about the mechanisms of labor, and I think you should know these. So when we talk about the mechanisms of labor, engagement is when that baby's head is at the level of the ischial spines. So this is engagement. Engagement has nothing to do with diamond rings. It's when the baby's head is at the level of the ischial spines. Descent is a constant as we talk about labor. The baby's head is always going down. Flexion. We want the baby to enter the pelvis with the head in flexion. So the little chin should be right down here on the chest in flexion. When it enters in flexion, this allows the smallest part of the baby's head here to go through the smallest part of the pelvis. If the baby should enter the pelvis in extension, what we have is a much larger diameter to go through the smallest part of the pelvis. This diameter here, when you have a brow, a face, or a chin presentation, can be as much as 13.5 centimeters, and that's not going to fit through the pelvis. But when the baby's head is in flexion, the part that has to go through the smallest part of the pelvis is the biparietal diameters, which is usually about 9.25 centimeters. And 4 centimeters of difference inside the pelvis is a lot of difference. So we have engagement, descent, and we want this baby's head to enter in flexion. Then, as it's in the pelvis, it has to move so the smallest part of the head can go through the smallest part of the pelvis. So that's called internal rotation. As the baby's head goes under the pubic arch, we see extension. About now, you may begin to hear a little wah. The baby's head is showing up on the outside here. Now, in order to get the shoulders through the pelvis, the baby has to turn. So external rotation, they have to turn to get the baby's shoulders through the pelvis. And then expulsion of the baby and delivery of the baby. So those mechanisms of labor, I think you should know. To summarize, engagement, descent, flexion, then internal rotation, the baby's head turns inside the pelvis, extension as it goes under the pubic arch here, external rotation, and expulsion. So one more time, engagement, descent is a constant, the baby's head enters in flexion. We see internal rotation to get the smallest part of the head through the smallest part of the pelvis. Extension as it goes under the pubic arch. Then external rotation to get the shoulders through the small part of the pelvis, and expulsion of the baby. Now that external rotation is actually something that Mother Nature does. Sometimes Daddy will say, oh, they let me turn the baby, they let me turn the baby. Well, actually the baby would have turned without doctor or Daddy or anybody else there, because it's a normal part of the delivery process. Truly a miracle for us. We want to talk now about the stages of labor. We just saw the baby, the mechanisms of labor, and now we talk about the stages of labor. First stage of labor is defined as the dilating stage. It's from 0 dilatation to 10 centimeters of dilation. So, and we divide the first stage of labor into 3 parts. Latent labor is sometimes also called the effacement phase or early labor. And this is from 0 centimeters to 4 centimeters of dilatation. And this latent phase, the contractions are relatively mild. They're beginning to come regularly. They're several minutes apart. They're lasting 20, 30, 40 seconds. Then active labor is from 5 to 7 centimeters of dilatation. And this is when Mother really starts using her breathing technique. So you're going to see her starting to use the breathing things that she learned in her childbirth classes. Then as she's into active labor, she's no longer chit-chatting with you. In latent labor, she might have been telling you about the nursery and her color scheme and all of that. In active labor, she quits chit-chatting, focuses on breathing. And as active labor progresses, the contractions are longer, stronger, and closer together. And then we have Dad doing things like rubbing Mommy's back during active labor. So all of a sudden, Daddy's rubbing Mommy's back, and Mommy says, "Don't touch me." Now we know that she's probably moving into transition, which is from 8 to 10 centimeters of dilatation. And usually as she moves into transition, she gets rather irritable. So that's when she yells, "Don't touch me." And we know she's moving into transition. The contractions that by now in transition are probably coming every 2 to 3 minutes, lasting 60 to 90 seconds, and they're very intense contractions. This is one of the most difficult stages of labor. Sometimes Mom feels like pushing during the transition phase of labor, but we can't let her do that. We don't want her to push until she's fully dilated. Now, once she's reached full dilatation, this is second stage labor, sometimes called the delivery stage, also may be called the expulsive stage. And from 10 centimeters till delivery is second stage labor. This is when all those mechanisms of labor that we just went through happen, and she's pushing this baby out. Once the baby is born, she enters third stage of labor, and from the delivery of the baby to the delivery of the placenta is third stage labor. Then once the placenta has been delivered, she's in fourth stage, and we usually define this as the first 2 hours after delivery or until Mom is stable. Now I might ask you, what's the longest stage of labor? And clearly that's the first stage of labor. We measure this in hours. It could be 10 hours in a prima gravida. Second stage labor is usually less than 2 hours. Typically it's somewhere between a half an hour and an hour and a half. If it lasts longer than 2 hours, we get concerned that something may be wrong. Third stage labor in the hospital is something like 5 or 10 minutes, because we usually give oxytocin with the delivery of the baby, and that hastens third stage labor. If you had an emergency delivery outside the hospital with no oxytocin, it could take 20, 30 minutes for the placenta to deliver, and that would be perfectly normal. Fourth stage labor is 2 hours as defined. Now let's do a question. A 26-year-old gravida 3, para 0, is admitted in early labor. She is not sure if her membranes have ruptured. She has had some leakage of fluid. After introductions, the nurse begins the assessment by saying which of the following. 1. Tell me about your other labor experiences. 2. How old are your other children? 3. Did you bring a sample of the fluid that was leaking? Or 4. Describe your contractions to me. Now be careful, this is a bit of a tricky question. Notice that she's a gravida 3 para 0. So there are no other labor experiences. The correct answer to this question is number 4. Describe your contractions to me. We do not ask women to bring samples of any leaking fluid. Now, if you are in the hospital and there's fluid and you want to know whether it's amniotic fluid or urine, you can do a nitrazine test or a pH test. Remember that urine is acid and amniotic fluid is alkaline. So urine would turn the pH paper and nitrazine paper red, and amniotic fluid would turn it blue. Another question for us. The nurse is caring for a woman in labor who is having contractions every 5 to 7 minutes, lasting 30 seconds. Her husband asks if she is in transition because his wife is getting restless and irritable and feels pressure. What is the best response for the nurse to make? 1. Transition is still a long way off. Don't you remember this from classes? 2. Her contractions are not typical of transition, but I will check her. 3. This sounds like transition. You are very observant. Or 4. It's impossible to tell where she is without doing an exam. Now, let me ask you, does this sound like transition or not? You notice that answers 1 and 3 are opposites. The answer is likely to be one of those two. Not 1 and 3, excuse me. Answers number 2 and 3 are opposite. And the answer is likely to be one of those two. So, are the contractions typical of transition or not? So her contractions were 5 to 7 minutes lasting 30 seconds. This is not typical of transition. Transition is Q2 to 3 minutes lasting 60 to 90 seconds. So the best answer for us is number 2. Her contractions are not typical of transition, but I will check her. Now, because we know that women don't always follow the textbook when they're going in labor and having babies. But these contractions are not typical. Transition contractions would be closer together and longer and stronger. Another question for us. A woman who is completely dilated is pushing with contractions. After 30 minutes of pushing, the baby is still at 0 station. What is the most appropriate nursing action at this time? 1. Assess for a full bladder. 2. Prepare for a cesarean delivery. 3. Monitor fetal heart tones. Or 4. Turn mother to her left side. And the correct answer is number 1. The most common cause of failure to descend is a full bladder. I have another question for you. As labor progresses, a woman becomes increasingly irritable with her husband and complains of lower back pain and fatigue. What is the most appropriate nursing action at this time? 1. Have the client turn on her side and give her a back rub. 2. Ask the client if she would like the physician to give her something for discomfort. 3. Reassure the husband that irritability is normal and teach him to apply gentle pressure to his wife's lower back. Or 4. Encourage the client to get some rest and suggest to her husband that he take a coffee break. And the correct answer is number 3. Now there's something I want to point out to you about these answers. If you look at choice number 1, the nurse takes over and gives the back rub. In choice number 2, we immediately go for chemicals, and that's not appropriate. In choice number 3, the nurse teaches the husband how to help his wife. That's the most appropriate answer. In choice 4, you get rid of the guy. You tell him, go get some coffee, get out of here. And that's not appropriate either, because we remember that it's usually a couple that's birthing the child. I want us to address a little bit about fetal monitoring. You need to remember that the normal fetal heart rate is 120 to 160 per minute. Some variability is going to be normal. Now, the next thing I want us to do is to look at patterns, the early and late deceleration patterns. There have been questions on NCLEX relating to early and late decelerations, and you should know these. If we take a look at this picture, we can see this bottom line here is monitoring uterine contractions. So we can see the contractions peaking here and then waning. The top line represents for us the fetal heart rate. If this is 100 and this is 180, this fetal heart rate is right about 140, which is where it ought to be, right in the normal range. And notice as the contraction starts, this is when the fetal heart rate begins to decrease. And it reaches its lowest point at the peak of the contraction. And then as the contraction wanes, the fetal heart rate goes back to normal levels. This is called early deceleration because the deceleration, the slowing of the heart rate, starts early in the contraction. And it reaches its lowest point at the peak and then increases back to normal as the contraction wanes or goes away. This is thought to be due to head compression and is a perfectly normal finding. So early deceleration is a normal finding. Now let's take a look at this picture. This picture shows a different pattern. First off, we notice immediately that the fetal heart rate is higher than normal to start with. It's up in the 180 range, which is higher than it ought to be. And notice here, as the contraction starts, nothing is changing up there. The fetal heart rate doesn't begin to go down until the contraction is well underway, close to peak. And the fetal heart rate reaches its lowest point after the contraction has peaked. In fact, it's just about gone away. This is called late deceleration, and this is an ominous sign. This is usually due to uteroplacental insufficiency. So we've got compression of the placenta, compression of the blood vessels. Late deceleration is caused by uteroplacental insufficiency and is bad. So now, to summarize, early decels are caused by head compression. They are a normal finding. Late decelerations or late decels are caused by uteroplacental insufficiency, and they are an abnormal finding. They might indicate the need for a cesarean section if they continue. So early decels are good, late decels are bad. Now we also see in this one a completely different pattern. If you look here, you see lots of variability. And you notice that the contractions, it's very variable when the decelerations occur. Some of them occur close to the peak. They onset early in the contraction. Some onset later in the contraction. So we have a variable onset. Lots of variability with the contraction. This is most likely due to umbilical cord compression and is kind of a watch and wait type of situation. So the variable decels are more of a watch and wait situation. Early decels were good and late decels were bad. And I think you ought to remember those things for your NCLEX exam. Now let's do a question. A woman has just had a precipitate delivery. What should the nurse observe, as it is the most common complication associated with precipitate delivery? Pitting edema of the baby's scalp, dural or subdural tears in fetal brain tissue, premature separation of the placenta, or prolonged retention of the placenta. And the correct answer is number 2. This is one of the big problems with a very rapid or precipitate delivery, is tears in the brain tissue, so dural or subdural tears. We want that baby to come out nice and gently without rapid changes in the pressure in the head and brain. Another question for you. A woman delivered in the car on the way to the hospital. In the emergency room, the physician examines the mother. What is the nurse's priority action? 1. Gently tug on the cord and massage the uterus to see if the placenta is ready to be delivered. 2. Clamp and cut the cord with sterile scissors. 3. Note and record the Apgar score. Or 4. Clear the mucus from the baby's mouth and nose. Now note that the physician is dealing with the mom, so somebody's going to take care of the baby, and that's you. And the first thing you need to do is number 4. Clear the mucus from the baby's mouth and nose so the baby can breathe. Air away. Keep them breathing. One would never tug on the cord. After the baby is born, the nurse may do Apgar scoring on the infant. And Apgar scoring is a score, a test to see how readily the baby is adapting to life outside the uterus. It was named for Dr. Virginia Apgar, so the letters don't really stand for anything. Now you notice on the scale that we've got 0, 1, and 2 points. So the maximum, and there's 5 items, so the maximum perfect score would be 10. So the baby's heart rate, if it's greater than 100, they get 2 points. If it is beating but less than 100, they get 1 point. And if there's no heart rate, 0 points. Respirations, if the baby has a good strong cry, wah, we get 2 points. If the baby has slow, irregular respirations or a weak cry, 1 point. No respirations, 0 points. Now, when we talk about muscle tone, most babies are born with good flexion, so both the arms and legs are flexed. If that's the case, both arms and legs are flexed, we're going to see the baby have 2 points. If, for instance, the legs were extended and the arms are flexed, the baby gets 1 point. If the baby looks like an old rag doll with just very flaccid in appearance and no flexion, there's 0 points. We also assess reflex irritability, and that's when they insert the catheter to suction the baby. If the baby objects, coughs, sneezes, cries, we give them 2 points. If the baby just goes, just a little grimace, they get 1 point. If they don't respond at all, then they have no reflex irritability and they get 0 points. Now we also discuss color. Most babies at birth are pretty pink. Regardless of race, they're all kind of pink. If they're pink all over, including the hands and feet, they get 2 points. If the body is pink, but the hands and the feet are blue, they have acrocyanosis, they get 1 point. And if they're all either blue or extremely pale, they get 0 points. Now, at 1 minute of birth, the real maximum score is going to be 9, because almost every baby loses points for color, because most of them have blue hands and feet, and sometimes even blue around the mouth. So they have acrocyanosis. At 5 minutes, and we do the Apgar score at both 1 minute and 5 minutes. At 5 minutes, it's possible to have an Apgar score of 10 because the baby may be pinking up. Apgar scores in the 7 to 10 region are good. The prognosis is good for the baby. 4 to 6, there's a bit of a guarded prognosis, and less than that, it's a serious problem for the baby. Now let's do a question about this. At 1 minute after birth, an infant is crying, has a heart rate of 140, acrocyanosis, resists the suction catheter, keeps his arms extended, and has flexed legs. So the nurse should record the Apgar score as. So now let's take a look at that. Crying, so that's 2 points. Heart rate of 140, 2 points. Acrocyanosis, 1 point. Resists the suction catheter, 2 points. And arms extended but flexed legs, 1 point. So this baby's Apgar score is